welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome to yet another primary snippet. So today we are going to talk about some of the pharmacology of opioids. So Maddie, commonly used opioids in ICU, obviously fentanyl, but also we are starting to see some of the increased use of remifentanil in ICU now. So can you please describe the pharmacokinetics of intravenous fentanyl and intravenous remifentanil, and then explain how these features create contrast between the two drugs?
So for any pharmacokinetic question, I've divided it into absorption, distribution, metabolism, and elimination. For some of them, you can also include the administration, but this question specifies intravenous. So don't really need to think about the administration because we know that it's an intravenous. You're comparing two intravenous drugs. In terms of the absorption, so from an onset of action point of view, fentanyl has a peak effect within 2 to 5 minutes. Remifentanyl's peak effect is shorter, so sort of more rapid. So it occurs within 30 seconds to 2 minutes. The rapid onset and offset of remifentanil and fentanyl actually allow for quick titration and easy onset. So they both are quite easy to use in an ICU setting. From a duration of action, fentanyl has a duration of 30 to 60 minutes after a single IV dose, and remifentanil has a duration of 5 to 10 minutes. So the duration of action is shorter, and the duration of action of fentanyl increases with prolonged infusion. But this isn't the case for remifentanil. For remifentanil, if we're using it in a prolonged infusion, it allows for predictable effects, unlike fentanyl, because fentanyl's duration of action will increase with prolonged infusions. From a distribution point of view, fentanyl has a volume of distribution at a steady state of 4 litres a kilo, which is much more than remifentanil's 350 mils a kilo. So the offset of effect of fentanyl is due to redistribution into fat and muscle, whereas remifentanil doesn't really redistribute in that way. They're both highly lipid soluble, but remifentanil is about 10 times less lipid soluble than fentanyl. So they both easily penetrate the CNS, but fentanyl rapidly redistributes into peripheral compartments like fat and muscle, like I mentioned before. From a pKa perspective, fentanyl has a pKa of 8.4 and only 9% is unionized at pH of 7.4, so physiological pH, whereas the pKa of remifentanil is 7.26 and 68% is so much more, is unionized at a pH of 7.4. So there's a faster onset of action of remifentanil as the larger amount is in its unionized form at a physiological pH. From a protein binding perspective, both do bind to proteins, but fentanyl binds more. So it's 81 to 94% protein bound, mainly to alpha-1 acid glycoprotein and some to albumin and lipoproteins. And remifentanil is 70% protein bound, and again, mainly to alpha-1 acid glycoprotein. Metabolically, they're quite different. So fentanyl has extensive hepatic metabolism and some intestinal metabolism, and it's got a high hepatic extraction ratio of 0.8 to 1. And it's mainly metabolized via the cytochrome P450 3A4 subtype by N-dealkylation to norfentanyl, then hydroxylation, and all its metabolites are inactive. Whereas remifentanil doesn't have organ-dependent metabolism. It is metabolized by rapid ester hydrolysis by plasma esterases, also to inactive metabolites. So remifentanil has no reliance on hepatic or renal function for metabolism or elimination. But in contrast, fentanyl is cleared hepatically. Therefore, in the setting of hepatic impairment, theoretically, the effect can be prolonged and there's a higher risk of adverse effects. Drugs that inhibit cytochrome P450 3A4 can potentiate the effects of fentanyl, but have no effect on remifentanil as it's not metabolized that way. However, the high hepatic extraction ratio of fentanyl is protective to an extent in terms of these metabolic issues, because with interactions with CYP3A4 inhibitors, clearance of fentanyl is dependent to a large degree on hepatic blood flow due to the high extraction ratio rather than the cytochrome P450 enzyme itself. From an elimination point of view, fentanyl has a slow hepatic clearance, so 75% of the administered dose is excreted in the urine within 72 hours, primarily as metabolites, and the elimination half-life is 7 to 12 hours in steady state. But remifentanil has organ-independent clearance, and 95% is excreted in urine as metabolite. Its effective half-life is much shorter, so 3 to 10 minutes, and the elimination half-life is 90 minutes. So elimination of remifentanil is independent of sex, weight, or renal or hepatic function, although elderly patients have been found to have increased sensitivity to the effects, so doses should be reduced in this population.
Thanks, Maddie. So also one of the terminology that we often use in context of opioids is the context sensitivity half-time. So can you please explain what is this context sensitivity half-time and also use some of the examples to explain this concept.
So, context sensitive half time is a time required for the drug's plasma concentration to decrease by 50% after cessation of an infusion. So, the context refers to the duration of the infusion, so how long the infusion has been running for. And a drug's context sensitive half time depends on its rate of clearance from the body, its distribution between the central and the peripheral compartments, and its volume of distribution at steady state. So, Remifentanyl has a context sensitive half time of 3.2 minutes, which is actually independent of the duration of the infusion. So you could actually say it's like a context, like independent half time, because the context is related to the duration. So this is because it has a small volume of distribution, rapid clearance by plasma esterases, and has minimal redistribution. If we compare that to fentanyl, fentanyl has a larger volume of distribution, as we just discussed. It has rapid redistribution to the tissues, especially fat, and has a slower elimination. So with prolonged infusions, the fentanyl that has been redistributed to the peripheral tissue compartments returns to the plasma, which maintains the plasma concentration of the drug, and it's then eventually eliminated by hepatic metabolism. So eventually the rate of distribution between the peripheral and the central compartments will be the same as the rate of the elimination of the drug. This steady state is the maximum context-sensitive half time, and it's about 300 minutes for fentanyl. So that's compared to 3.2 minutes for remifentanil. So you can see that in an ICU population where we're running prolonged infusions for patients, the effects of fentanyl can take a long time. So a long time to actually be negated, I guess, for patients, even once we've stopped the infusion.
Thanks, Maddie. So this concept is often asked in primary, and we might use the graph where the different drugs are plotted on the graph, and then you need to identify which drug belongs to which context sensitivity half-life curve. And interesting to understand, although we choose fentanyl in ICU quite frequently, it has got a long context sensitivity half-life because of its lipid solubility. So it's not that it's a very short-acting drug. It actually can hang around in the body for a while. So thanks, Maddie. That's the end of our today's snippet. We'll be back with another snippet in a few weeks' time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.